All right. Hello, everyone. My name is Kate Marquis, nurse here at Life Support Learning Center, and welcome to part 3 of our sensory assessment series. We're talking about touch today. So going back to our objectives, identify 2 ways that each of the following senses can influence the assessment of your patient. And again, we're on our 3rd one down here, touch. We do have 2 videos before this about sight and sound. You can get to those in our links, and we'll be coming up with our 4th one on smell shortly. Always talking about the why. This hasn't changed from our last presentation or the one before that, but we can gather so much information about our patient just by utilizing our senses. We always worry about things like equipment failure and the accuracy of our numbers when we're getting them. So to be able to go in to utilize our senses, it can give us a really big hint on where we kind of need to start with our patients, as well as whether or not our patient is really in a bad way. So touch is really wonderful because it can help us evaluate multiple body systems at once, as well as evaluate multiple assessment pieces of a single body system. And what that means we'll talk about more in a minute. All right, let's talk about our condition insights here. Circulation and perfusion is a big one when we talk about touch. There's a lot of information that we can get just by laying hands on our patient. And this is kind of what I was referring to in multiple body systems. So you can see circulation, exposure, and trauma here, injury rather, as well as the multiple pieces within circulation and perfusion. It's the multiple assessment pieces of a single body system. So talking specifically about circulation and perfusion, we'll start with skin quality. So I'm looking for my skin to be pink, warm, and dry, so to speak. That will tell me whether or not my patient is perfusing properly, because that will be one of the first things that the body kind of shuts off, so to speak, if the patient gets into trouble. So you'll see the patient become cool. You may have mottled skin. They may be pale. They may be diaphoretic. So I'm really looking at the skin quality as a reflection of whether or not they're perfusing, and I can get that from touch. Additionally, I'm looking at my pulses. I'm looking at my central versus my peripheral pulses. Again, my patient starts to get in trouble, especially we talk about things like hypovolemic shock, or even if you're looking at a distributive shock like sepsis, my peripheral pulses are going to be the first ones to kind of shut down there. So I'm looking at the quality of my pulses. So are they bounding? Are they thready? Or is it fast? Are they slow? Is it regular or irregular? I can get a whole lot of information just by laying hands on the pulses of my patient and even comparing the two of them. I can tell whether or not my systolic blood pressure is in an okay place or not. If I have a radial pulse, I have a hot second. My systolic blood pressure is probably greater than 80. It's probably around 90 or thereabouts. If I don't, I know that my systolic blood pressure is definitely on the lower end, because everything is going to start shutting down as my patient shunts their blood kind of to their core, so I'll only be left with my central pulses there. So there is a ton of information that you can get from pulses, bounding versus thready. Are they septic and so they're bounding? Are they thready because they're hypovolemic and they're bleeding all over the place? Regular versus irregular. Is my patient kind of shutting down a little bit because they have an arrhythmia that they're not able to kind of compensate for there? Is it fast or slow? I don't necessarily need a number off the bat. I just need to know, okay, this is too slow for a patient to be doing well with it, or too fast for a patient to be doing well with it, or it's okay. Moving on to edema, pitting edema. There are various levels of pitting edema. So someone's leg looks kind of big, so I can actually go in and lay hands on them, say, oh, well, their right leg has all of this pitting edema, and you can actually press in on the patient's leg or ankle or what have you, and actually see the indent. So that can tell me a little bit about the patient's fluid status. Moving on to exposure, this is kind of a trauma nursing core course or an emergency nursing pediatric course language. So I'm looking at the temperature of the patient. When I lay my hands on them, is their skin hot? Is it a normal temperature? So were they just working out in the fields? We have a lot of farms in this area. Were they just shoveling snow and they were working really hard? Were they just cutting the grass? Are they cool to the touch? Were they hanging out in the snowbank outside, because it's always February in my classroom? Do I expect them to be cool to the touch, or do I expect them to be hot to the touch? Are they febrile? Are they hypothermic? If they're cool to the touch, are they cool because they were sitting in that snowbank? Or are they cool to the touch because they're not perfusing properly? When we talk about injury here, this is just one example of many. You're going in and you're doing your full trauma assessment, and you're ensuring that everything is intact, because not all deformities are super obvious, right? So you're going in, you're checking all of the limbs, and you're checking the pelvis, and you push on the pelvis, and you hear the crunch, which kind of goes back to our last lecture in sound. But as well, you can actually feel kind of bones give. So that certainly has a feeling as well. Another example that we have up here is subcutaneous emphysema. So you think about Boerhaave syndrome. I've probably just butchered that pronunciation, but so that esophageal rupture there. Or you can talk about laryngeal or tracheal lacerations. These are all things that can cause subcutaneous emphysema. Certainly not a total list there, but these are all things that can cause that subcutaneous emphysema, where you go in and you press it, and you can actually feel the trapped air beneath the skin, and it sounds like Rice Krispie treats. So these are all things that we need to kind of think about, and you can lay hands on and identify that maybe this patient doesn't look super swollen yet, but you have, in fact, that sub-Q emphysema there. That is a little bit about touch. We'll be working on our next lecture on smell. So thank you for joining me, and I hope to see you guys again next time.